So we'll start with acute kidney injury. Most of you, if you're practicing, have encountered it. Yes, there's a new definition. In 2012, KDIGO came up with the definition that if any of the following criteria are met, increase in serum creatinine by 0.3, or if there's a 1.5-fold increase in creatinine over the past 7 days, or if there's oliguria, that means urine output of less than 0.5 milliliters per kg per hour for at least 6 hours, you call it acute kidney injury. But I can tell you, nobody actually looks at this definition when you're actually defining it. For me, it is still, again, if you look at the physiological concept of it, it is still sudden loss of kidney function, which happens over hours today. And there's an imbalance of what metabolic waste which you are producing and what is being excreted. And most commonly, it is reflected by rise in creatinine or decrease in urine output, right? Uremic waste, and of course, blood urea nitrogen is also part of it. But sudden decrease in kidney function is all what we use clinically. And nobody remembers this definition. Most of these definitions have arisen from or have arisen from research studies, because we wanted to actually standardize how do we study acute kidney injury. Now, this has not changed. The framework of approaching acute kidney injury, I can tell you, has not changed since you were in medical school, right? So it's exactly the same. How do you think about acute kidney injury? So it's either pre-renal, that means the kidney is not receiving the blood supply either at the right pressure or right volume, or there is post-renal, which is there's some obstruction in the urinary flow. The urinary flow is obstructed, there's back pressure on the kidney, and there's some damage. And then what is left is the kidney itself, that the kidney itself could be damaged, and that is intrinsic acute kidney injury. Now, if you go back to, again, if you can visualize a slide of a kidney biopsy, or if whatever you remember from your pathology, if you remember what is there in a pathology slide. So there's a glomerulus, which is the heart of the nephron, right? It is the main filtering unit. If that is damaged, we have acute glomerulonephritis, which is causing acute kidney injury. Now that glomerulus is attached to tubules. So if that tubule is damaged, it's acute tubular necrosis. So there's no memorization here. And surrounding the glomeruli and the tubule, there's interstitium. If that is damaged, of course, it is acute interstitial nephritis. And within that interstitium, there are blood vessels. If there's something going around there, some damage in the vascular space, we call it acute vascular syndromes. Right? So it's just a framework. But now let's say you are a betting person, you went to Vegas and you were like, somebody is coming in with acute kidney injury, you're admitting somebody. I'm not saying I'm not using an example of an outpatient acute kidney injury, but you're admitting somebody with acute kidney injury, and somebody were like, can you take a guess? What is the cause? I can tell you 9 out of 10 times you're gonna have these causes. Either acute tubular necrosis, pre-renal, or post-renal. So 5 out of 10, it is going to be acute tubular necrosis. 3 out of 10 is going to be pre-renal. And 1 out of 10, it is going to be post-renal. So 9 out of 10 are these 3 causes. And of course, what does the board likes to test? The 1 out of 10. I have no idea why. Right? They should be testing the 9 out of 10. Of course, now I think there is a drive towards checking common things common, and again, not look for zebras, but yes, they do concentrate on that 1 out of 10 too.